Well, hello, everyone. It's my pleasure to welcome you to this ASPPH Presents webinar, which is reporting on our recently released report, Healthy Longevity, a framework for research, education, practice, and policy. Next slide, please. I'm Linda Freed, and I have had the honor of serving as the chair of this ASPPH Healthy Longevity Task Force, which developed this framework. Next slide, please. I will be joined today by my four eminent colleagues, Dr. Jay Olshansky, professor at the University of Illinois, Chicago Campus School of Public Health, Karen Bandine Roach, Director of the Training Program on the Epidemiology and Biostatistics of Aging and Professor of Biostatistics at the Johns Hopkins Bloomberg School of Public Health. Lisa Renzi Hammond, Director and Professor at the University of Georgia College of Public Health, and our own Tim Leshin, Chief External Relations and Advocacy Officer at ASPPH. May I have the next slide? Today, we are launching ASPPH's Healthy Longevity Initiative. This will offer a framework for research, education, practice, and policy. Next slide. The challenge for us is that we have really, primarily through public health, extended the length of our lives by 30 years in the last century. This is an astounding accomplishment, and 25 of those 30 years are due to public health interventions. But now, despite the additional length of our lives, Americans are living in poorer and poorer health. And in fact, there is a widening gap between lifespan and health span, with the final 12 years of people's lives in poor health. The opportunity comes from the evidence that prevention works and matters at every age and stage of life across the full life course, and appropriate intervention and investment across the life course results in healthy aging. However, we have not yet democratized the results of what we already know, and there are large gaps in terms of how to make this an opportunity for every American and every person. In fact, public health, with its expertise in prevention, population-level capabilities, interdisciplinary approaches, and commitment to leading for change, is essential to elevating population health and creating a future of an increased health span that approximates the length of our lifespan, a future where every person has the opportunity across their life course to live with health and to have the opportunity to age, to live well, with health, with purpose, with function, and connection. By accomplishing this, starting with academic public health, we can set the foundational goal for all of public health and lead a shift from lifespan as our outcome measure to health span, which will parenthetically also increase lifespan. By doing this, we can create a future where aging is an opportunity for health for all and is not viewed as a state of inevitable health decline for long years or societal burden, but instead as an opportunity to ensure everyone the opportunity to live to their fullest potential. Next slide, please. So today we offer a strategic framework for action: public health academic leadership across 4 pillars: research, education, practice, and policy and advocacy. And we offer evidence-based recommendations for action by ASPPH, its member schools and programs, and beyond. Next slide, please. For each It is time to understand what the science tells us and to make investments, to prioritize funding for education, to prioritize educating a future workforce that can lead on the creation of healthy longevity, to prioritize translating that science into system redesign that prioritizes prevention and rebalances this country's investments in treatment versus prevention in order to deliver what will create healthy longevity for everyone. And finally, to reframe our policies towards an opportunity and optimism of what we now know is possible, which is to create longer lives with health. Next slide, please. What we're going to propose is considering these 4 pillars within a new context, public health 4.0. We all know that public health has been defined by the Institute of Medicine, the National Academy of Medicine, as what we can do as a society to ensure the conditions in which everyone can be healthy. But how we do that is based on how our knowledge has progressed and how our investments have yielded results. We began over 100 years ago conceiving of what became Public Health 1.0 70 years ago, the foundation of our current public health system, which has dominated our approach to public health through the 20th century and is considered the foundational basis through scientific discovery, infectious disease control, and basic infrastructure for surveillance and translation of science into policy or practice. This was modernized through the early 2000s with additional emphasis on chronic disease prevention, epidemiology, behavioral sciences, and more structured and effective public health systems. And then in 2016, a vision was proposed by Karen DeSalvo and colleagues to amplify Public Health 1.0 and 2.0 with a 3.0 perspective, in which public health system leaders serve as chief health strategists for their community, with goals of coordinating across sectors so as to better address the roles of social determinants of health while delivering community-based prevention, and also emphasize public-private community partnerships, technology advancements, and the import of achieving health equity. This vision has marked tremendous evolution in our framing of public health, its roles and responsibilities, how academic public health needs to contribute, and the opportunities we could collectively create to improve the public's health. But as I already said, between disinvestment in public health nationally over the last 60 years and inadequate ability to translate public health evidence into workforce training and the systems we need, the population health in the United States has been deteriorating over the last 40 plus years, marked very much by the National Academy report about a decade ago on shorter lives, poorer health. So today, we add a 4th goal, to make the creation of long lives with health or healthy longevity a blueprint for the next generation of academic public health and our public health system, Public Health 4.0. This is built on the goals of Public Health 1 through 3, with a move from lifespan to healthspan for all as our compelling goal. It will require academic public health investment and leadership in creating the knowledge and education for interventions to create positive health futures for everyone at every age and stage, so that everyone can have the opportunity for healthy longevity. It will require academic public health translating the knowledge into workforce development and into system redesign for public health, and how to align a modernized public health system that creates healthy longevity with medical care and social systems so that we can collectively accomplish primary, secondary, and tertiary prevention in the second half of life, as well as the first. Lengthening health spans so that they approximate the increased length of our lives needs to be the work of academic public health, providing the knowledge, the evidence, and educating the workforce and driving to translation. According to the National Academy of Medicine's 2022 Global Roadmap for Healthy Longevity, public health systems are the single most powerful structure for preventing chronic conditions and equitably improving population health. Lengthening healthy lives would require preventing the development of chronic diseases, disability, frailty, and cognitive declines emergences at older age, and directing public health to prevent emerging issues such as loneliness. Life course evidence that guides us to next-gen public health strategies is critical, and the return on investment would be very high. Greater health at every age, healthy young people aging into healthier older people who are able to remain engaged in society and contribute their immense capabilities. To achieve this, Public Health 4.0 has to be led from academic public health. Next slide, please. So to lead us through our 4 pillars of work in this context, it's my pleasure to turn to Professor Olshansky. Jay.
Thank you, Linda. First of all, thank you for having me here. I'm absolutely delighted to be part of this group. I've got a short story to tell and one image to tell it. It's going to be fairly straightforward. So just by way of background, about 8 years ago, I was invited by the American Medical Association to discuss this very issue that we're talking about today. During that discussion, they asked me if I would create a single image to convey this concept of life from lifespan to health span, which they published in 2018. And so let me explain what this is, because I think it addresses the foundation of what the logic of this concept of lifespan and health span 4.0 and public health 4.0 is all about. So for those of you who aren't familiar with demography or population statistics, this is actually fairly straightforward. This is a figure showing what's called the distribution of death by age. It's also the distribution of life by age. So if you look at the black line, what you're seeing is the number of deaths that would occur at every age based on the death rates that existed in 1900 and in 2016 for females in the United States. It pretty much looks like this everywhere in the world today and way back in 1900. So the black line is a classic illustration of high infant, child, and maternal mortality. This is what Linda was talking about earlier. Public health successfully brought down this early age mortality. You could see maternal mortality, that bump right at about age 20 to 21 for females. But even way back in 1900, if you made it past those first couple of decades, decent chance of making it out into 60, 70, 80, and even 90s, but nothing like comparison to today. So what did we do? In the last century, in the 20th century, we brought down this early age mortality. We shifted the distribution of death or the distribution of life into later ages so that most people had an opportunity to live beyond the age of 65. And that's where we are today. It was nothing less than a remarkable achievement of public health and medicine, which led to a 30-year increase in life expectancy. Nothing like this has ever been achieved before. I've argued that for a variety of reasons, it's probably not going to happen quite like this again in the future. You can only save the children once. So we have to celebrate the lives that we've created, the time that we've manufactured through public health and medicine. It's been absolutely remarkable. But there's a Faustian bargain that's associated with these longer lives. We've pushed people into outer regions of the lifespan where they become exposed to the biological process of aging, which I refer to as the red zone. That's that red area over to the right. So yeah, we've succeeded in making ourselves live longer, and we need to celebrate that. But the price we've had to pay is the rise of heart disease, cancer, stroke, Alzheimer's, sensory impairments, a whole suite of things that go wrong with older bodies as we push out the envelope of survival. So what modern medicine has been doing, of course, is attacking one disease at a time with success, but with diminishing returns in terms of gains in life expectancy. But it might very well have been pushing out the envelope of survival deeper and deeper into the red zone, where the risk of frailty and disability rises exponentially. So, Ernest Groenberg back in the 1970s referred to this as the failures of success. It's like, be careful what you wish for. If you get these longer lives, in all likelihood, you're going to get something along with it at later ages that you may not like. And that's where we are today. So the whole concept of lifespan to health span is really not about trying to push out that blue line, about trying to make us live longer. It's about trying to compress the red zone, to delay the onset and age progression of the things that go wrong with older bodies as we live longer lives. And that's where public health, I think, can make a major contribution, public health and medicine. And I've used this particular figure as a supporting argument for geroscience on why it is that we need to find a fundamentally different approach to medicine and public health going forward. In this case, one that zeroes in not just on the diseases and disorders that occur in older bodies, but the underlying biological process of aging that contributes to the rise and expression of these diseases. And if we can delay the onset and age progression of the things that go wrong with us at older ages, zero in on health span rather than just lifespan, I think the return on investment that Linda was talking about earlier will be huge. And it's not just monetary value. I don't know how you even put a price on a year of healthy life. But the moment you lose it, the value rises pretty dramatically. So I'm going to stop there, and that's my 5-minute spiel on what we've done to ourselves and where we're headed. So thank you, Linda. You're on mute, Linda.
Perhaps we should just move to our next speaker, please. Karen, I think you're up.
Well, once again, if we could have the next slide, then it's my privilege to be a part of this group as well. It's been a tremendous experience, and it's been such a joy to contribute to the education and training part of this report. I think we can boil down the main items from our section of the report into two ideas. The first is that public health education writ large is the place for education on aging, not only aging-specific programs. And that's for sure because of the tremendous harvest of health to be gained, as Dr. Olshansky, just so compellingly told us about, and Dr. Fried has told us about. But there's also this idea of the point of the spear, which I've stolen from Dr. Fried, and the idea that late life provides a particularly keen lens by which to evaluate the declines in health, but these aren't just rooted in old age. Of course, they're rooted in midlife, and those declines are rooted in early life. And so we have honest hope and belief that scholarship and ultimately training around aging has the power to improve health at every age. And so hopefully this is a compelling reason for public health education writ large to embed aging scholarship. You can see that in the first few bullets, that we consider it essential to reframe public health education around health span so that we can equip all graduates with knowledge and tools to promote health across the entire lifespan. That healthy aging and foundational public health, its presence in core curricula, really can heighten its relevance to the entire lifespan, and that it's not sufficient to rely on training in just generic skills and competencies around health, but there are special issues related to aging in which specialty training is needed to prepare the future workforce to produce healthy longevity for our whole society. The second key idea of our report is to combat the old notion that training in aging is not sexy and that it's difficult to engage students in interest around aging. We have found exactly the opposite. And, there are definitely strategies by which it's actually quite easy to engage student interest. Aging is so inherently interdisciplinary and complex. It presents wonderful problems. Experience-based learning is not only important, but essential. And so again, this really engages students. And so all of this provides ways by which to expand student interest in aging, particularly if we present aging not as a decline, but as a compelling intellectual and practical challenge relevant to all stages of health. If I very briefly go through some of the bullets at the bottom of the slide, you see these same two ideas woven through. And so the first to ASPPH leadership is to provide all of the ASPPH members with resources and exemplar models. Our report finds that fewer than a third of ASPPH member institutions have specialty programs in aging. But in those that do it, there are wonderful examples. We have a program at Johns Hopkins in interdisciplinary and the epidemiology and biostatistics of aging that has really proven success at being able to attract interest in students who weren't necessarily interested to start with. So to disseminate those models. Secondly, to define the essential competencies and knowledge for students regarding healthy longevity. And these may differ a bit along the stages of training, whether it be MPH or doctoral degrees or continuing education. But some of those elements include the cells to society and to the environment determinants of aging. Health promotion strategies that can provide access to healthy behaviors for all, a holistic view of our health beyond the sum of diseases, which in aging we think of as the frailty to resilience spectrum, frailty at that part of being in a state of decline that we don't want, but resilience if we compress that red zone that Dr. Olshansky showed. Inherent complexity with determinants across size, those scales from cell to society, time across the life scores, space scales, multimorbidity, polypharmacy, care coordination, really a tremendous set of challenges. The next three bullets, the bottom one for ASPPH and the first two for the member schools, all have to do with incorporating life course prevention and perspectives into all relevant courses. And it's not hard. Complexity of determinants mandates a population view. It's not something that can be studied in small samples. This makes epidemiology the basic science of the future, which will need to be integrated with basic sciences. There are incredible challenges for biostatistics, data science, and the emergence of AI. Life course study is a pillar of public health writ large. And then finally, vulnerability often is rooted in environmental determinants, social factors, disparities, behavioral elements. And so really policies to address all of these challenges and create opportunities for all, as well as to coordinate services, really brings in all the core domains of public health. Aging is exciting, because of the interdisciplinary aspect of it. We really aim to foster transdisciplinary students who embed multiple different sets of expertise needed to address the challenges of aging, whether they go on to be practitioners, professionals, or experts. And then finally, the last thing I'll highlight is the very last bullet, is delivering programs in a way that can be exciting for students via experiential learning, practica, partnering with communities. The opportunities are limitless. The excitement is there, and we believe that this will yield tremendous benefits, not only for students, but sustainable benefits of innovation, discovery, and better health across the lifespan going into the future. So with that, I think I will pass on to our next speaker, Dr. Renzi Hammond.
Thank you. All right, so I have, I think, one of the most fun tasks on this entire panel, and that is to take what you heard from research, our attempts to focus on compressing that, compressing the red. And you heard, Jay talk beautifully about that. You just heard Karen present about how to start really thinking about our curriculum in ways that support healthy longevity. Practice is where all of these things come together, right? Practice is evidence-based. And ideally, we are sending extremely well-trained students out there into the world to occupy these practice sites. So time to be ambitious and think about redefining what the practice site is. In Public Health 4.0, we are not calling for putting slightly better trained students into the same places we've always put them to train with the same job ambitions they've always had. In fact, it's so much more radical than that. And it gives us in academic public health a chance to dream, right? To really think about what the world would look like if we did it differently. So it calls on us to think about the spaces that public health occupies. Yes, you will find us in our state health departments, in our local health departments. You'll find us in DC, you'll find us in places like CDC and EPA. This is true and has always been true. Where do we belong, though, to start thinking about actually implementing prevention at every level? What are our roles in our communities, right? Where are we in clinics, in hospitals, in places where public health desperately needs to exist? So if we're thinking about redesigning the system aspirationally, thinking about the places where we belong, where we practice, and where we should be making a difference, particularly in prevention, it becomes all about partnerships. As academics in public health, we have the opportunity to help our students select from extraordinary professional experiences that engage in that active learning component that Karen was just talking about, but that help our community partners really understand the value that public health brings. If we are placing our students instead of just those traditional places, if we're thinking about things differently and putting public health into clinics, right, into practice spaces, into our organizations that are developing communities geared for healthy longevity, then we're not only boosting the experience of our students, we are teaching those in those new spaces that public health can really do something for them to help them achieve their mission, right? When we start thinking about our goals as translational, that public health members of the workforce are vital and important and key human beings in these various workspaces where we may not have existed before, then we get closer to our implementation goals. So my challenge to all of you, right, in academic public health, which really, as you heard from Linda, has to lead the way on this. My challenge to all of you is to think about the professional experiences that you're placing your students into. Think about the connections that you've made to achieve those research goals that Jay mentioned earlier, right? These are all potentially wonderful workspaces for our students and for our trainees, where we can take what we learn in research, take those well-trained students, allow them to be our ambassadors into practice spaces that are new and particularly effective, and let those relationships grow and flourish. It means thinking about our competencies in ways that address stakeholders we may never have addressed before, codifying them, and then making those connections to get our students into those spaces. So I'm going to leave it at that because this feels very, very aspirational and might, in fact, involve us thinking differently about policy and where our students work in those spaces. So I'm going to turn it over to our next speaker to accomplish that in just a moment.
Thank you so much, Lisa. And I really want to thank Dr. Freed for leading the charge on this important report from ASPPH. It was her vision and her leadership to get us to this point. And thanks to all my fellow speakers too for being here to talk about this report and why we think it's important. I do want to make the case that, we're going to have to change public policy in order to implement this kind of approach across the board. And I think that there's actually a really interesting window for us to start doing this sooner rather than later. Now, I'm sure many of you saw the passage of the reconciliation bill, which passed last on the 4th and was signed on the 4th, and some cuts to Medicare and to other social services programs that are in there, which is troubling, right? But quite troubling, and we were pushing back on that. But there there are other ways to try to tackle some of these problems through this healthy longevity lens. And I was, looking at the Make America Healthy, the MAHA movement. We have not endorsed the MAHA movement, nor have we criticized it. We are just looking at it as a potential opportunity, because what is MAHA trying to do? They really are trying, under the leadership of RFK Jr. and President Trump, to prioritize improving overall health and addressing chronic disease with a particular focus on children's health, which isn't exactly the healthy longevity frame, but obviously healthy longevity happens across the lifespan. And so if you look at some of their principles, some of the things that the MAHA movement is trying to do, they're focusing on chronic diseases for children, and focusing on ending the quote epidemic of childhood chronic disease. This includes addressing issues like obesity, diabetes, and other conditions that can impact long-term health and lifespan. They're also looking at the root causes. MAHA's commission is investigating the underlying factors contributing to health disparities and chronic disease, including early childhood experiences and education, food safety, and community resilience. Now, I'm not saying that we would all share the same view on how they would prioritize these issues, but I think you're getting a sense that there's an opportunity for us to work basically bipartisanly on this issue of healthy longevity, because there is a focus in the current administration on these chronic disease issues, which is critical for healthy longevity. And we know that on the other side of the aisle, that the Democratic perspective is that we need to do a whole lot more to provide the services and the policies in order to enable healthy life. And as Dr. Terry Fulmer has said to us, we really can't also forget about those who are sick, who are older and are dealing with chronic diseases now. And we made a big point in this report to also talk about the importance of focusing there. So I think there's an opportunity here. And so what have we said? We've said that there needs to be some policies that are where we reframe the focus on prevention and connection and equity across all ages. And healthy longevity should be established as the core national public health goal throughout our investment in this space. And our schools and programs can really be empowered to lead and shape the policies related to healthy aging and shifting the narrative away from the negative view of aging and more towards one where we think about how can people who, as they age, continue to make a major contribution to our society. So I really am excited about having this framework now to work with all of you, but also to bring it to policymakers in the administration on Capitol Hill, and also bring it to industry and other voices so that we can try to gain broader support for this new approach, which is a lot more logical if you think about it, and could be a lot more impactful but we'll need to make sure that policies change to support this approach. And that's a daunting task, but one that we're excited to push forward. I think.
And listen, thank you to all of you for fabulous presentations. I'd like to turn to a few thank yous. First, to the broader membership of the Healthy Longevity Task Force for ASPPH, and all of the members are listed here. And of course, those of us who were able to attend today are representing the whole group. It was quite a great experience. What I'd like to do, because we have a few more minutes, is to ask a couple of questions of the panelists and then turn to you, our audience, to invite you to ask questions as well. I'd like to go back to a point that Jay Olshansky made, and we all understand as academic public health, which is that the learning and evidence that we glean through public health science changes our view of what the opportunities could be, as well as what the necessities are. I'll give as one example where we started, that we now know with reasonable confidence what we didn't know 40 and 50 years ago, that prevention works and matters into the oldest ages and works and matters at every age. We couldn't assert that decades ago, even a few decades ago. And it works for chronic diseases and has the potential to work for the other conditions that emerge with older age that Dr. Olshansky talked about. We also are learning that the health promotion side of public health matters here as well. And I will say that there is very exciting emerging evidence that shows that not only can we prevent the ill outcomes of older age, but people accrue immense assets. All of us have the opportunity to accrue immense capabilities as we get older, socio-emotionally, cognitively, which really matter for the well-being of society and offer a potential of social capital with generosity, with the elements of wisdom, with a desire to leave the future better for younger generations, for future generations, at a scale that we never had before, with 20 to 25% of the population being older. So these real breakthroughs in terms of knowledge change the frame of what the future could be. And so I'd like to turn to our speakers to say, what do you think both the return on investment would be of success in this ASPPH initiative for academic public health? And conversely, what are the risks if we don't do it? Maybe I'll start with anybody who wants to leap in.
I'll take an initial stab if that's okay.
Please.
So actually, first of all, the point you raised just a moment ago about the benefits of public health. Look, we've got a demonstration of the negative effects of the harmful behavioral risk factors acquired early, right? So you can start a group of, it happened in the middle part of the 20th century, people smoking. There was a latent effect, and we saw the negative consequences. We saw the negative consequences of the acquisition of obesity in the latter part of the 20th century. It has been playing itself out over the last 25, 30 years. So I think the point to be made here is that the opposite is also true, which is the foundation of public health is these interventions that can happen at any age, by the way, whether you're a child or in middle age or even at older ages. The benefits are measurable, and some are latent. They may take years or decades to observe, and some may be quick. So I think a lot of the work that you're talking about, that we are talking about here, we can be confident that these changes in public health that we're advocating for, we may not necessarily see all of the benefits immediately, but we are likely to see them play themselves out over the coming decades. And we have a history where we can make these observations. That's what public health has been doing for a long time. Real quick note on return on investment. I mentioned this during my presentation, and I've been talking about this for a long time. Of course, we've done calculations on what the benefit would be if we could slow aging by a small amount, right? If I recall correctly, it was, 1 year of healthy life added to a population is worth something like $37 trillion. And sure, that's the money side of it, but how do you calculate the impact of adding just 1 year of healthy life or avoiding 1 year of unhealthy life? And it's difficult to put a number or a value on that, but all I can say is that I've been giving thought to this for a long time, and I've not come up with an answer that is a good one on exactly how to address that particular question. What I do know is that the moment you lose healthy life, you suddenly recognize and appreciate the value of having it.
Perhaps one could add that there's good evidence that for Americans that people who are disabled, people can live with chronic diseases up to a certain point of severity, but when people become disabled, generally as a result of those chronic diseases, as well as some aging-related processes, they cannot engage in their lives, their families, their communities, or in giving back in the ways that they want to. And we lose that. And what we know is that even where we are from a health point of view, David Bloom at Harvard has shown that about 7% of the US GDP already results from the contributions through paid work or volunteering of older people in this country. What if we could amplify that by giving the rest of older people the opportunity for health? Karen, Lisa, Tim, do you want to add any comments?
I'd like to add two quick threads. One definitely builds upon what both you and Jay just said, which is the tremendous opportunity to increase health. So we're already at a point where 20% of our population roughly is 65 years or older. So it's an enormous number of people, whether in the United States or worldwide. What an incredible store of health. If you imagine even one life year and all of those people, let alone all of the health to be gained at earlier ages. And, these problems of how to achieve that are so complex. And Jay referred to the long view. Some of these will take years to develop. It means that you really need to embed this in an academic setting, that is devoted to innovation, which is training the next generation to carry on discovery, all of those sorts of things. And then the other thread has to do with education specifically. I just made the one point about the sustainability of carrying through the long charge of reaping all of these benefits. There's one that I forgot to mention in my comments, though, which is that we feel that education should not only be for students who are enrolled in public health programs, but the larger public, including the older adult public. And so there's a return on investment to be made in engaging the public throughout our nation, in a critical aspect of public health and why it is that academic public health gives so much to improve lives, and how can we learn from the public to do it even better.
And Karen, it's just such a perfect way to build from a practice perspective, right? There's a million long-term gains that we can talk about. But there's also some really important immediate gains that we can mention, right? When we take these trained students, when we sit down within our colleges and our schools and our programs of public health, we get together and we dream and we say, what are the spaces where we need to belong, where we need to practice to be able to achieve public health 4.0, which means healthy longevity, right? When we expand our concept of this, we include maternal child, right? We start really thinking about the entire life course as a life course. and an entire world of practice opportunities opens up that we may never have thought of before. And when we can take students and place those students into new practice sites, right, that aren't just our typical places where, you know, students usually tend to go, or where our new students envision having a career someday, we also bring job security to those students, right? We all know lots of somebodies who have been affected by job cuts. Expanding our ability to practice into new places, right, that can be safe harbors from some of those, you know, from some of those more whimsical situations that we see, we're guaranteeing our students job security, right? They're starting to see themselves as being ambassadors of public health into community spaces where they may never have thought about practicing before. It also opens us up to new students who may think that all we are is COVID-19.
Thank you. So Tim, do you want to add anything to that?
If you don't mind, I would. First of all, I want to acknowledge Lynn Goldman put a comment in here about MAHA focus on children, as that is part of healthy longevity because it starts with children, and I totally agree with her on that. I wanted to just offer up one very specific proposal that is in the Congress now that really builds on this concept, and this is the Cure Hepatitis C Act, which was introduced recently by Senators Cassidy and Van Hollen. And the idea is if we did an upfront investment and really cured at least 2 million, if not 4 million people in this country of hepatitis C, we won't see the financial and health consequences that would happen if people don't get cured from hepatitis C. And we can cure it. We just need them to get the resources that they need in order to get that treatment. And so that's an example where we know from the Congressional Budget Office that it would at least save $7 billion for the US federal government if we were to cure hepatitis C. And that's the kind of thing we need to do more of. Very tangible public policy activities that can affect the lives of humans and make their life healthy throughout their whole life.
So if I can maybe pull together a frame here from something from what each of you have just said, it's very clear that the costs of not doing this are very high. The cost of not doing this is to leave the status quo where people are living more and more years in the United States with more and more ill health, to have an older population, 20 to 25% of the US population, with ill health at high rates that is preventable, and to lose the assets and the capabilities that people want to contribute as they get older, while adding up across many life years, more ill health that people have to struggle with. And as Jay said, that's even before we get to financial costs, which are huge. I could imagine that the converse of investing in a public health system that can deliver the conditions for healthy, long lives in every community would quickly turn to schools and programs of public health to ask for the workforce that could deliver this cutting edge knowledge. And we have a critical role to play to be ready for that. So thank you all. I'd like to turn to you, our audience, and invite you to enter questions into the Q&A. I see two already. One from Lynn Goldman. Lynn, thank you. And I think Tim already responded to say that, of course, how we invest in children's future as well as present health is the foundation of whether they have the opportunity to live long lives with health. That is absolutely essential anchor starting place. For Ekaterina Noyes, I hope I pronounced your name correctly. Karen, do you want to respond, because you really, or Lisa, you both spoke to whether caregiving, formal and informal, should be part of a public health curriculum?
I imagine we both will have something to say, and my answer would be absolutely yes. And, you know, it can be done at various levels, but I'll tell you in our own training program, of not only epidemiologists, but biostatisticians, people who come to the field, not necessarily devoted to aging. We include in their training a practicum, which involves not only engaging in care of older adults in clinical settings, but also home settings, including caregiving. And you can imagine when they first hear that they're going to do this, some of them are like, isn't that maybe a waste of my time? We find that uniformly they come back and say that, it's been an enormously valuable part of their training, not only to see the fuller spectrum of public health opportunity of levers that we have to improve health and well-being, but also even for understanding data and for designing analyses and those sorts of things that you just can't appreciate unless you experience it in some real way. Maybe I'll let Lisa follow on that.
Yeah, since Karen, as always, did such a beautiful job of summarizing, the sort of avenues for working with caregiving in a setting, in an academic setting, I would say that if we think again about the challenges that we in academic public health face, right? These illusions that students have, as I said earlier, that we're all COVID-19 and nothing else, right? Or that you're only an epidemiologist, or you're only one of these things. I think the beautiful thing about caregiving is it's a great opportunity to find a curricular niche that not only allows you to connect programming in your school of program to other units. So for example, these are things that we discuss a lot with our MSW MPH students, and we give them applied settings in which to work on those problems, but they're relevant to MD MPH students, and they hit the lived experience of a lot of our folks, right? So we try in our Institute of Gerontology, for example, to bring in not only current students who are working on MPH degrees and the sorts of professional degrees, but people who are working in the aging workforce, who are trying to continue to bolster their training, and other members of our communities who tell us this is what they need. That also helps us boost practice sites. So if you think, we know the philosophical reasons to include curriculum on caregiving and caregivers, but pragmatically speaking, right, it's a great way of connecting our academic programming to things that are happening in other units to show those students who may not have thought of public health that we're a great space for them to learn. We have something to offer them that they might not be getting in the rest of their curriculum.
Thank you both. And if we pull apart what caregiving means from a public health point of view, I think there's a lot to be developed here. We could think about it adding to primary and secondary prevention, some of the dimensions of tertiary and even quaternary prevention for people with health or function challenges who can really achieve the meaningful lived lives in the face of the right kind of caregiving. We could also think about the health challenges to caregivers, which are substantial, and how a public health system could contribute to preventing or mitigating those. And we can think about really as we take some lessons from COVID-19 about the failures of our current nursing home system design and capabilities, and listen to the experts on long-term care urging that we move to more community and home-based long-term care, then it's the right time to be asking what the role of the public health system should be, what the role of the area agencies on aging should be, how could they work together to provide that kind of prevention. So thank you for the question, which I think I hope we unpacked somewhat. There's a question here from an anonymous attendee who says, as I think about the positive impact we see currently being latent, this person says, in thinking about a research study, it implies policy related to grant making has to be confronted as well. I'm inferring that this means what grant funders will fund in order to enable us to get the data we need. Jay, or anyone else, do you want to comment on this?
Yeah, boy, that's so obviously there have been numerous problems with funding in the field, recently. I don't know how much longer that's going to continue, but clearly that's a serious issue. And I think we need to recognize the long-term impacts of issues associated with funding for basic science and basic research. The one thing that keeps coming to mind as I'm listening to all of you and to the first question that came up was the echo effect of early life developmental events and change, which relates to all of these questions about the life course and how changes that are made and decisions that are made early in life echo through biological time. So the things that we do or don't do early in life influence us when we get up into our 60s, 70s, and 80s. And a lot of the research that is perhaps not getting funded today is perhaps focused on some of those echo events. And I think we need to realize that sometimes the consequences of the research that's going on aren't necessarily immediate. It may take a while for us to see the consequences of 4.0, but rethinking public health the way we're talking about it here does require, as Lisa indicated, a foundationally different way of boxing in these concepts. I don't know if I answered your question, but that was what came to mind.
It also, I would suggest before I give Tim the last word here, that we need to educate people interested in funding the next generation of cutting edge research to understand that there are upsides to longer lives, which we need to understand, tremendous upsides. It's what we all want, and how to bring out the full capabilities and meaning and purpose of those is not a completely wide open set of questions, because we now know enough to know that there is a lot to learn. So it's my honor to turn this over to Tim Leshin to close out this webinar. And Tim, over to you.
I didn't mean to get the last word, but I appreciate it.
Pleasure.
I want to end on a hopeful note. I mean, I think the next generation of folks who are entering public health are interested in having a larger impact. And I know public health has been under attack recently, but we feel that this report is a framework for everyone to use in order to have a more hopeful look at the future of public health and really change the narrative from one that's like the nanny state that people have worried about to one where we're really promoting everyone's health over their lifespan and having a bigger impact. And so there are opportunities in all the realms we talked about: research, practice, education, and public policy for the next generation to help us achieve this goal.
Thank you for that. And now, to stay within the time allotted, could I have the last two slides, please? First, to tell you that this webinar has been recorded and will be available on the ASPPH webinar event page very shortly. And you can capture the information here on the screen. And last, just to say thank you to all of you for joining us. If I can have the closing. This, we believe, I think the entire task force that ASPPH teed up for this report, we believe that this could, if we all embrace it together, really offer the reframe for the next part of the 21st century that can really create the opportunity for everyone to have not just long lives, but long lives with health at every age and stage of life. So thank you for being here. Thank you for what we can do together to implement this. And I'm pleased to say that upcoming is another webinar on August 11th on truth-telling in the age of health misinformation and disinformation. And we hope to see you there. Thank you all so much. Take care.
Thank you.